today about antepartum hemorrhage. Now, there's quite a lot to cover, so do stop me or ask me any questions as we go along. But it should all be quite straightforward. Hopefully, nothing too new to any of you. So stop me as we go if you need to. So what is antepartum hemorrhage? So antepartum hemorrhage is any amount of bleeding, isn't it? So any bleeding from the genital tract from 20 weeks up until birth, and it may or may not be accompanied by pain. And it can affect up to 5% of all pregnancies. And if we think of how many patients we see in day assessment, we might come in with a little bit of spotting just on wiping, to a little bit in their underwear, to full-blown bleeding, which is running down their legs. So we know it can vary in how much, in quantity, and it's not always necessarily something terrible going on. Lots of different causes for APH, so you can get placental abruption, which we know can be with or without pain. So with or without bleeding, actually, there would be pain. Placenta previa, uterine rupture, vasa previa, which is extremely rare, but we do see it occasionally, so it's something that everybody needs to be aware of. And then you've got other weird and wonderful things. Well, I say weird and wonderful, so abnormal placentations such as placenta accreta, increta, and percreta, but this is obviously becoming more and more common with the more cesareans that patients are having, and we'll all experience this in our training, perhaps more so at Oxford because it's the tertiary centre for more complicated abnormally invasive placentas, but we will all come across it even in the DGH. And any amount of bleeding can pose a risk to the fetus or to the mother, but remember the mother's always the primary concern. And potential complications, it depends on the extent of the bleeding, doesn't it? So either it's not very much, and there's nothing that you're worried about, or there could be significant bleeding, which can cause maternal hypovolemic shock, can affect her clotting. Sometimes you may need to deliver patients, or they may deliver early themselves, and there's also risk of fetal hypoxia and intrauterine death. So usually it's completely fine and benign, but it can be obviously very significant and have lots of morbidity associated with it. So let's look at a scenario. So we've got a 43-year-old who's a para 2. Let's say she's had 2 term vaginal deliveries, and this is an IVF pregnancy. She had a bit of bleeding in her first trimester, but otherwise she's been okay. She's coming at 32 weeks with reduced fetal movements, constant abdominal pain, and some spotting on wiping. When she comes in, she's obviously a bit anxious. She's in a little bit of pain, and her blood pressure is 175 over 104. In her urine dip, she's got a plus of protein, 2 pluses of ketones, and there's a trace of glucose. So you proceed to examine her. She's got a normal BMI, but and her abdomen is soft, but it is a bit tender lower down, and the fundal height is 28 centimeters. You put on the CTG, and there's reduced variability, variable decelerations. What's running through your mind at this point?
She's abrupted, maybe due to preeclampsia. Yep.
So you're thinking abruption. And with abruption, we know that that can be one of the complications of preeclampsia, isn't it? Everyone's happy with that. What else could it be? Any other thoughts?
I mean, she's got lower abdominal tenderness. We don't know the mode of the first delivery. Maybe it was a C-section, and there's scar tenderness, uterine rupture.
Yeah. Yes. Absolutely. Was that Vinod? That's right. But I should have put on here, but for argument's sake, we'll say she's 2 times vaginal delivery. But yes, if she'd had a cesarean before, you obviously have to think about the scar. And so it's always important to make sure you get an accurate history. So placental abruption. So this is when some or all of the placenta can separate from the lining of the womb, and it can either be with or without bleeding. So with bleeding, we know it's called a revealed abruption, and if there's no bleeding, then it's called a concealed abruption. So the absence or presence of bleeding isn't necessarily the be-all and end-all when it comes to abruption. But what's important is that the patient will complain of pain, and this pain will be constant pain because it is the infiltration of the blood into the myometrium. and it's usually over the site of the placenta. So if their placenta is anterior, then they're going to complain about anterior pain. If their placenta is posterior, they'll complain more of backache and back pain compared to abdominal pain. That's just something to be aware of. Obviously, when you examine them, their uterus, they may or may not be tender, or they'll be tender to some extent. And you'll come across this term of Cuvier uterus, but this is a very rare complication of abruption, and this is where virtually all the placenta has separated and the blood has gone into the myometrium, and you just end up with this tender, hard, woody abdomen, and that's not something that we see very often at all. And if you do come across a patient like that, she'll be significantly unwell, and the chances are the baby's going to be dead as well. So that's a Cuvier uterus. If you'll read about it, hopefully you don't ever come across it. So the patients may also present with contractions. So sometimes it can become, sometimes it's not so clear cut, because they may complain of some constant pain, but then this intermittent tightening physically. And we know that's because abruptions can occur in labour, or they could stimulate labour. So again, it's important to get a good history as well. There can be an element of fetal distress depending to what degree of separation there is, and if obviously a large enough part of the placenta has separated, and usually there are other factors going on. So maybe there's a small baby, reduced liquid volume, but there's an increased risk of IUD. You always need to assess for the evidence of DIC, simply because we know that abruption is associated with that risk, and these women, they can become quite unwell, unstable quite quickly, especially with massive abruption. So that's something to be aware of. And with massive abruption, all that blood pulled into the uterus, the patient may be in shock. So you need to look for all these signs and symptoms. So that picture is just basically showing a concealed bleed there, as you can see, and then here, this is where the bleeding is able to come out. So there may or may not be bleeding. So when it comes to investigations for placental abruption, there isn't actually very much that you can do, because it's a clinical diagnosis. But you obviously want to rule out things like labour, for example. But you would want to do basic bloods, so make sure there's a valid group and stay. Always check that there's a historical one. If it's a massive abruption, or you're worried about the risk of DIC, you may want to cross-match some blood for her as well. You need to check the clotting and fibrinogen in line with that, and a fibrinogen of less than 2 would suggest a severe abruption. What's a normal fibrinogen in pregnancy? What do we aim to keep it above?
Is it 4?
It's 4, yes. That's a good number to know. So that's what's normal in pregnancy. So anything lower than that, especially less than 2, is significant. And you'd also want to send off a Clyhow just to make sure that there's not been any mixing of maternal fetal blood as well, because that can have its implications. Now, would we want to do an ultrasound in this setting? So you've got this patient, she's complaining of pain, she's got a bit of spotting, you put her onto the CTG, and we've got this dodgy trace. Do we want to do a scan? Do we think it helps us with abruption?
In this case, it's probably likely
You wouldn't want to delay. Yeah.
Sorry. What was that? Sorry.
Would you want to just check if the baby's alive? So you might scan them in theatre, but before you take them to theatre.
Okay, so I guess it depends on the nature, how severe or not you think the abruption is. But generally speaking, if you've got to a point where you're suspecting the abruption and there are CTG concerns, you don't want to waste time doing the scan, because that baby needs to be delivered, doesn't it? Because if you're suspecting abruption, it's not going to get better, and that baby and the CTG is just going to deteriorate. So it depends on where you are. If, for example, you've got somebody who's got a little bit of pain, a little bit of bleeding, she's otherwise stable, her obs are fine, her CTG is normal, and maybe she's a little bit preterm, then yes, you could do a scan. But you're not looking for anything related to the placenta, you're just looking for live, so presentation, maybe you want to just reassure the patient that the heartbeat's there. What if you could see an abruption on scan, what do you think the significance of that would be? Does it matter?
If it's visible on ultrasound, does that mean it's quite large?
Yes, exactly. If it's that's exactly it. If you can see it on the scan, then that's a significant abruption. Don't waste time. Obviously, get on and deliver. I mean, you would obviously want to check that there is a fetal heart, because you will get patients who will come in with an IUD secondary to an abruption. So yes, in that case, you know, and there's usually a history of reduced movement, or maybe the midwife is struggling to find the FH or the CTG, then you will definitely want to do a scan to check that there's a fetal heart there, because otherwise you don't want to have to rush somebody to theatre to deliver a dead baby. So yes, there can be a role, but if you can see a significant abruption on scan, that baby is not going to survive much longer. And actually, the CTG would have been abnormal before then. So it can have a role, confirmed fetal heart, yes, but it depends on the scenario that is presented to you. But you shouldn't routinely do a scan, and if you're as sure as you can be clinically that it's an abruption, especially in the presence of CTG concerns, you just need to get them and deliver the baby. Don't fuck around too much with the scan. And also, it's not a sensitive method of diagnosing an abruption. You'll see, if you know what you're looking for, you might see large abruptions, so large clots sat behind the placenta, but you're not going to see smaller ones. And if you're not trained to look at placentas anyway, then again, it's a bit pointless doing a scan. So in emergency, it's not advised. It's based on clinical grounds, unless you obviously need to confirm the fetal heart. So risk factors. Sorry, this has come out a bit small. So let's go through these and just have a think. Which of these do we think would be risk factors for placental abruption? And I know it's really difficult, and if you all end up speaking at the same time, don't worry, but it would be nice to get you guys involved. So hypertension or preeclampsia, is that a risk factor or not?
Yes.
Yep, definitely 100%. It's one of the things that we worry about, isn't it, when the blood pressure is uncontrolled in terms of fetal risks. There's definitely risk of abruption. Smoking?
Yes.
Yeah.
Yes, definitely. Cocaine use, because, you know, we see lots of women using cocaine.
Yes.
Yes.
It is, exactly. Causes like vasoconstriction or something, so they can definitely be at increased risk. Folic acid deficiency?
No.
Apparently there's some evidence, it's not particularly strong evidence, but if it is, that there can be an association with folic acid deficiency. So that's why it's important, you know, our diabetics, anyone else that's at high risk, so women who are obese with raised BMIs, that we do give them folic acid, but supplementing them won't necessarily take that risk away. But there is some weak evidence that it does affect. It can increase risk. Trauma?
Yes.
Yeah. What happens with trauma? Why the abruption?
Is it because you hurt yourself enough that the placenta gets separated physically, or?
Yeah, the shearing force. So if you imagine a car accident, that force of going back and forth, sometimes it can be significant enough that it can tear the placenta. And same again, you know, domestic violence and trauma to the abdomen. It obviously have to be significant trauma to the abdomen, but it definitely can cause abruption. Thrombophilia, I think that says. It can do. Again, not quite sure exactly, but it's thought that there might be small microclots or something that forms at the placental bed, and that can increase the risk. Pre-prom, so preterm premature rupture of membranes. What do you think? Somebody that's come in 32 weeks, who's got anhydramnios, or even oligohydramnios.
Yes.
Yes, it can. Again, it's one of the things, if somebody starts to have bleeding in that kind of situation, you need to really be conscious of it and think about whether or not there could be an abruption going on. Multiple pregnancies.
Yes.
Yeah.
In what setting? When is it going to happen with a multiple pregnancy?
More chorionic.
Actually, it's more delivery of the twins and when the delivery of the second twin. So it's more the dichoriomnia, DCDA twins, because once the first twin is born, the placenta separates, then there's a risk of abruption with the second placenta. That's why you have a short time frame of delivering the second baby, because we know there's that risk of abruption. Advanced maternal age. It's all very boring, isn't it? Yes, there's an increased risk with that. Low BMI, bleeding first trimester, assisted conception, previous history, all of them are risk factors for abruption. So, I mean, hopefully do you remember the bulk of them, but it just goes to show that there are a lot more than what you would typically think. So, okay, I didn't realise I'd done these individually. So smoking, yeah, 90% increased risk, depending on how many cigarettes they smoke. Folic acid may reduce the risk of abruption. We spoke about trauma. So
Ms. Chohan, can I ask, why would assisted contraception predispose you to abruption?
So potentially there's been some trauma that's been created to the endometrium at the time of the IVF. But again, it's all very unclear. But it's just the evidence when they look at these cases that there's a high incidence of abruption. And maybe these women have had more pregnancy losses. Have they had surgical management? So anything that's really kind of disrupted the endometrium, it could potentially increase their risk of abruption.
Thanks.
And with PPROM, is the mechanism like, is it due to infection or what? Why does that increase the risk of abruption?
Not necessarily infection. It's partly they're more likely to go into preterm labour, and then you haven't got that nice cushion of the lycra cushioning the baby. So just the not necessarily the contractions as such, but it's just the early labour side of things that they may go that it may cause an abruption, and it's small abruptions. It's not going to be all of a sudden she's okay, she's ruptured a membrane and then she gets a massive abruption, but you may get small abruptions. So again, if the lycra changes colour, so you're not just looking out for yellow greeny lycra colour, which would imply infection, but if it starts to become bloody, then that's when you start thinking about abruption. So if I finish that one, previous history. So yeah, previous history, if it's happened before, about at least 10% chance after one and about 20% chance after two abruptions. So that's just something to know to tell patients. So what are potential complications? Don't know why I've written infection there. Anyway, mother could become anemic, hypovolemic shock, could develop VIC, you can get multirenal involvement, obviously, depending on the degree of shock. And there's also risk of PPH or fetal-maternal hemorrhage. And obviously the psychological sequelae of having to go through something like that is quite traumatizing. And in terms of potential problems with baby, IUD be the worst case scenario, but then obviously hypoxia with illness, sequelae, risk of baby being anemic as well. And sometimes you'll get women who keep presenting intermittently throughout their pregnancies with small bleeds, a bit of pain, and it's almost as if they're having small abruptions, but there's no way to confirm this. But again, they're someone that should be considered high risk, should be kept under consultant care. They will need to have serial growth scans to make sure that there's no fetal growth restriction. And if there are, or obviously if the episodes are getting worse, bleeding is getting worse, or the pain is getting worse, then considering early delivery or delivery around 37 weeks is something that we might consider. Anything anybody wants to ask about abruption?
Ms. Johan, I would just want to know, are abruption and placental infarction correlated?
That's a good question. So infarction would imply that there's an area that's obviously lost its blood supply and it's died to some extent. So to my mind, yes, there must be a correlation between that. But again, sometimes you'll see reports on the scan where it says that the placenta looks a little bit mature. They wouldn't necessarily say infarction and things. Again, I guess there is always a risk or a worry of abruption because those patients, you wouldn't let them go overdue, for example. You would probably think about inducing them, delivering them definitely by their due date. So there must be some correlation. Okay. So if we look at painless antepartum hemorrhage, because obviously abruption is always with pain, so you can have placenta previa and you can have abnormal placentation. So placenta previa, essentially it's just a low-lying placenta, and depending on the degree that it's covering or reaching the cervix, you can grade it like 1, 2, 3, 4. About 5 to 28% of all pregnancies will have a low placenta at 28 weeks, simply because the placenta is in the lower segment. But the vast majority of those will, I say, grow, but they will grow with the uterus moved out of the way by term. So there's only about 3% which will remain low by term by 37 weeks. So, and low is when it's 20 millimeters from the internal os, or if it's covering the cervix completely. And you can have minor major, so minor means it's just reaching, so it's just less than 20, and that it can be anterior or posterior, and they're more likely to move out of the way as the pregnancy progresses. And major are the ones which cover the cervix, and those are not going to move. If you've got someone with a low-lying placenta that's covering the cervix at 20 weeks, yes, we go ahead and we do rescan them at 32 weeks, but the chances of them moving out of the way are virtually zero. So again, you can give a patient some sort of idea of what to expect for their pregnancy and delivery. Risk factors are smoking, advanced age, assisted reproductive techniques, and a previous cesarean infection. And as I said, we would rescan all these patients at 32 weeks. And then depending on what we find, if it seems that the placenta is moving, but it's still low, then we will offer, or we will do another scan at 36 weeks. But obviously, if it's still covering the cervix at that point, then we will just look to planning delivery. So signs and symptoms, some of these patients may be completely fine, asymptomatic, they'll have no problems with bleeding, whereas you'll have a proportion of those women with the low-lying placenta who keep presenting again and again. And I'm sure we've all seen it. And what do we find with the women that have these bleeds? What happens as the pregnancy progresses? What's the nature of the bleeding? So we usually find that the bleeding gets more frequent, larger volumes as the pregnancy progresses, and usually they end up having such large bleeds that we're then prompted to deliver them. So that's what happens to some of those women. So it could just be, they could be asymptomatic, small amount of bleeding to complete soaking through and being torrential, life-threatening bleeding. So we always recommend that they don't do anything too strenuous, and to avoid sexual intercourse, and you should always tell these women that they should come to hospital to be assessed, regardless of how much bleeding they've got. Even if it's a bit of bleeding on wiping, they still need to come in to be assessed. So with the low-lying placenta, you're also more likely to get fetal malposition, so babies are more likely to be breech or transverse. And that's also something to be aware of in multips, especially. If a multip has got a breech presentation or transverse presentation, then you should be suspicious of it, because, especially with a transverse presentation, because you need to think, well, why is it transverse? And have we possibly missed a low-lying placenta? And so in that case, you could always pop a scanner on and just locate the placenta. In terms of management and delivery, obviously it depends on each individual patient. If you've got someone that's completely fine, see them in clinic, scan at 32 weeks, scan at 36 weeks. If it's moved out of the way, great, go for vaginal delivery. So it has to be more than 20 millimeters. If it's still low, they also need delivery by cesarean. And depending on the how low or not this is the placenta previa is, timings recommended between 36 and 37 weeks, according to the Royal College. And they also recommend giving steroids somewhere between 34 and 35 plus 6, because remember, we plan cesareans before 39 weeks. We need to give these patients steroids to reduce risk of neonatal RDS. For those women who keep having recurrent bleeds, they may just need to sit in hospital then until their delivery. That's not particularly fun, but especially if they live far away or they haven't got transport, that's sometimes what may happen. And then obviously being aware and counselling women that with a low-lying placenta, they're more likely to bleed at the time of delivery. So you need to be prepared for major obstetric hemorrhage. So make sure you've got all the right bloods, cross-match, you've asked for cell salvage, theatre team know, the anaesthetist knows, you've discussed it all at your WHO and things, and there can obviously be a risk of hysterectomy. So make sure you've gone through that with the patient and the team is aware of everything. Any questions or comments about placenta previa? Again, it's fairly common, it's becoming more and more common with all the cesareans that we're seeing, so you'll all be involved with placenta previa. So abnormal placentation, this is when the placenta is abnormally adherent to the endometrium. So you've got a normal placenta here, you can see a clearly defined border between the placental edge and the endometrium. Then you've got the placenta invading in through the endometrium, but still the myometrium is generally intact, as is the serosa. And then with increta, it's going right through the myometrium, but still hasn't broken that serosal surface. And with percreta, it's gone all the way through. And the percretas, they are very rare. As I say, perhaps if you're in Oxford or in a big tertiary centre, you might well see these. I've never come across this, but they can even extend if it's anteriorly, invade into the bladder. That's the most common scenario, but obviously depending where the placenta is, it can invade anywhere. Does anyone have experience of that? Possibly not. Okay.
Yeah, in Oxford.
Yeah.
For quite significant, actually. It's really interesting.
Yeah, and you can get, and I remember actually Emma did a presentation, Emma Layton did a presentation on an interesting case last year, actually. So yeah, if you're going to see it more, you're going to see it in Oxford, but it takes a lot of planning to and good counselling to manage these women. So as I said, the incidence is increasing because of the number of cesareans. If you've had one cesarean, your chances of abnormal placentation is 3%. And then you can see if you've had 5 or more cesareans, it goes up significantly. So this should always be your main focal point when counselling women, especially primates, who say, yes, I want to have a cesarean. I've read everything on Dr. Google, ask me, quiz me, I know everything. And the whole point is that we want to try and avoid primary cesareans for this reason. Yes, we talk about better recovery for the patient and everything else, but this is what it all really comes down to, because if you can stop a cesarean from being done in the first instance, obviously where it's indicated you need to do it, but where it's just patient choice, for example, next time round, you never know, she might end up with an accreta or increta, and really you need to think, was that the right choice for the patient if we end up with this complication? So this is what we're trying to reduce the risk of, and you should be consenting patients for this when you're talking to them about consenting for cesarean. And what I would normally say is we talk about the risk to your future pregnancy, which is always the last thing on your mind, especially when you're in labour or you've just about fallen pregnant this time, but you need to know the implications for your next pregnancy. So incidence rate has increased tenfold, and the risk factors, if you've got a low-lying placenta, previous history, although I would hope you're not going to come back too often if you've had abnormally adherent placenta, previous cesarean, any other uterine surgery. So it could be something as simple as a hysteroscopy and you've had a perforation, something so simple, but if that leaves a scar on the endometrium and the placenta embedded into it, then that's usually the logic or the reason behind these things happening. So maybe she's had a surgical termination, D&Z, something like that, but there's something that's obviously disruptive for endometrium. Advanced maternal age and assisted reproductive techniques. So it's not as benign as we think, having IVF and things like that. It does have lots of potential complications. Everyone okay so far?
Yeah.
So this, it looks quite busy, but I think it's a nice run through. I think it was from either the TOG guideline or the college guideline, I can't remember now. But you can see at the top, if you've got a low-lying placenta, less than 20 millimeters on a TA scan, you could consider a TV scan if you want to. So if the placenta's at the back or the patient's got a raised BMI. If they've not had a previous cesarean section, then you scan them again at 32 weeks. And then, like it says, as it says, if it's still like asymptomatic, deliver between 36 and 37 weeks. If they've got recurrent bleeding, then you need to give them steroids. Think about when you're going to schedule the cesarean, do they need to stay in? If they are asymptomatic, low-lying placenta, you repeat their ultrasound. Can't see this bit, sorry. This box of mine won't move out the way, and it's really annoying me. Never mind. But yes, the important thing is if someone's had a cesarean before, so if they've either had a previous part of the spectrum, any of the problems before, that goes without saying. But if they've had a previous cesarean, they've got an anterior placenta, that's when you really need to stop and think. And this is more so for the sonographers because they're doing a 20-week scan. But you need to think then, could there be an abnormally adherent placenta? And then they would need to have more specialist scans, so by a fetal medicine consultant. And sometimes I know we will send patients up to Oxford if we're not particularly sure. And if there are then signs of that, some women go on to have an MRI, but generally speaking, we would refer them onto Oxford. So that's generally how you would manage an abnormally adherent placenta. So you always think about previous section, anterior placenta. If it's not been thought of already, when you see this woman in clinic, go to the sonographer, ask any of them, have a quick look at the scan, does it look okay or not, and then escalate it as needed. So another scenario, you've got a 32-year-old completely low risk who comes in with some pain and bleeding at 38 weeks. When you examine her, she's got some fresh bleeding on the speculum and she's about 3 centimeters dilated. So what could be going on?
Normal labor.
Yeah, she could just be in labour, couldn't she? Okay. Anything else?
She could have still had a small abruption.
She could well indeed, yes. And those are the two likeliest scenarios, aren't they? The other thing is, have we missed a low-lying placenta? Something else to think about. We do come across these. We do come across it occasionally, but let's assume that it's a high placenta. Okay, fine. So what would you do with this patient? What will be the next steps?
Blood cannula and admit for monitoring.
Yeah. Would anyone do anything else?
Maybe keep her on labour ward or in like the obs bay or something.
Oh, absolutely. That's always very important to think about. So was that Vinod before? You're completely right. You're not going to send this patient home, are you? So you're definitely going to want to keep her in. Then you need to think about where is the best place for her. Is this someone that you need to keep a close eye on? So does she's not quite in labour, is she? She's only 3 centimetres, but you don't want to send her up to the ward either. So the observation area would be ideal. What else would you want to do with her?
Would you put her on continuous fetal monitoring if she's got ongoing bleeding?
Yeah, absolutely. You need to do a CTG. Now, I don't want to give the game away. I can't remember what I've written in the next bit of the slide, but you must do a CTG because really that's going to determine what your next management is going to be. So let's say if a CTG is completely fine, what would you do?
Thrice a day CTG and do a presentation scan.
I mean, you wouldn't necessarily have to do a presentation scan unless on palpation you thought she wasn't cephalic. At 38 weeks, you would hope that it's been spotted, or maybe at your VE, you know she's cephalic. But the point is, you'd be quite happy just to observe her, wouldn't you? Yes, she's got a bit of bleeding, but we think she's in early labour. She's 3 centimetres. CTG is fine. Just keep her in the observation area and await events, essentially, isn't it? Just see what happens. Either things will settle down or things will progress. Maybe she'll go into labour. What if there are concerns about the CTG? What else would you want to do? What's one more thing that we could do to also assess for fetal well-being as well? Would anyone do an ARM? I would. So you've got somebody that's come in with fresh bleeding. I know I've been very vague with the fresh bleeding. Is it just a bit of spotting? But let's say it's a significant. Let's say she's got like a 50 mil APH there. It's significant, and your CTG actually you're not quite happy. You're not terribly happy about it. How many weeks is she? 38. So let's just say there's a bit of reduced variability. She might have only have been on it for about 10 or 15 minutes, but the variability looks reduced, and you've got someone that's bleeding. Personally, I wouldn't say, well, let's just wait another half an hour. Maybe the baby's just asleep. I would think, you've got someone who might be in labour, but she's bleeding and there's reduced variability. She's ARMable, so I'm going to ARM her. That's what I would do. Because also you can then assess the colour of the light core as well. Is it clear? Is it bloody? Is there meconium?
I'm guessing you would have done an ultrasound if you didn't already know where the placenta was. You would have made sure the placenta wasn't low-lying before doing that.
No, I wouldn't, because if she's not had, so she's been completely low risk, there's been no episodes of bleeding, she's had a VE, so we've managed to do a VE, we've established that she's 3 centimetres, we've not felt anything funny, you'd feel something on VE, so no, I wouldn't routinely do a scan, unless obviously we don't know where the placenta is, so technically don't stick your fingers in to do a VE if you don't know where the placenta is. So if she's come from somewhere else, or she hasn't got her notes, or you're not sure about presentation, but I wouldn't routinely scan her, no. So then let's see, what did I say? So we take her to delivery suite for an ARM. We've got our cannula, everything was done. So you do an ARM and there's a heavy PV bleed and a fetal bradycardia. What do you think is going on?
Does that point us towards abruption?
No.
Or was it
Vasoprevia?
Vasoprevia, exactly. Now, have many of you heard of vasoprevia? Does anybody want to tell us what it is? So it's something that's, as I said before, it's something that's extremely rare. But this is your classic scenario. Someone's either come in for induction or they come in with a bleed, and an ARM is performed, and immediately following the ARM, there's a significant bleed and then a fetal bradycardia. And that combination, you need to think of a vasoprevia. You need to think about it and act very quickly, because otherwise you're going to end up with a dead baby. So it's really rare, I keep saying it, but slightly higher risk with IVF. Again, don't ask me why, but I can only think that it's the disruption to the endometrium, abnormal plus sensation, all that kind of stuff. Now, 60% of these women will have a low-lying placenta, and usually they would have had a transvaginal scan with Dopplers as well, just to make sure that there isn't a bit of cord or vessels going across the cervix. But it's defined as fetal vessels which are crossing the internal cervical os through the free placental membrane. So if you have a look, and there can be 2 different types, and they can either be protected or not by the Wharton's jelly around the cord. So if you have a look at the first one here, you've got velamentous cord insertion, meaning that the cord is inserted on the side. And can you see there's no Wharton's jelly covering the vessels there? So the vessels are essentially bare. And then there's a bit of jelly there as it goes into the umbilicus. So that's one scenario. Or another scenario is when you've got the main placenta, but then you've got a subcenturiate lobe. Again, I don't know if anyone's come across this, but you can get caught out by this like sometimes. But this is an extra lobe of placenta. And again, they're just, these vessels are just running freely across the cervical os without any protection or anything. So you can see in both of these scenarios, if there was a rupture of membranes and then there's pressure from the fetal head, or if you were to do an ARM through there, how you could nick the fetal vessels or they could burst spontaneously. And remember, and that's bleeding from where? From mum or baby?
Baby.
Baby.
It's baby. And what's fetal blood circulation? It's not very much.
Mils?
Pardon?
Something like 300 mils?
Yeah, it's not. It's. I think it's even less than that, Emma. Chloe, sorry. No, it's not very much. But so if you imagine that there isn't much in the fetus anyway, and you do this ARM and there's this big gush of blood, albeit mixed with liquor as well, so it will always look worse. That's an emergency situation. You've got to do category 1 section straight away. So that's why you need to think about this problem and act on it promptly, because otherwise these babies will all become sick very quickly, and obviously they can die.
It's supposed to be 85 mils per kilo at term. So yeah, depends how big your baby is.
Okay, thank you. So now that I've scared you all to death, you're going to think twice before you do an ARM. But as I say, it is very rare for this to happen. And usually we know about it beforehand because it's mostly associated with a low-lying placenta, but definitely something to be aware of. So I think I've got, this is a nice picture. So it's diagnosed by a combination of TA and TV Dopplers. So you can see this is the cervix here. That will be the presenting part, whatever that is, probably breech or something. Lycra is there, the dark space, and these are the vessels that are just running freely across the cervix. So that is not something that you want to go poking and prodding at all. Now, we don't do universal screening at the 20-week scan because there just isn't the evidence to support it. I guess because it's so rare, you would have to scan, I don't know, so many women in order to find and prevent one vasoprevia. But again, it's for the sonographers really, for them to have that suspicion. And then if they are worried, then they would escalate to fetal medicine. So it's diagnosed in the second trimester. It might resolve in approximately 20% of patients. So they always have a rescan at 32 weeks. Again, transvaginal scan with a Doppler. Where it is diagnosed antenatally, you can imagine survival rates for baby are obviously better because you can plan an early cesarean section. And we would generally keep them in usually from about 30 to 32 weeks because you obviously don't want them out in the community wandering around with the risk of SHROM at home. Give them steroids in 32 weeks, and we will generally deliver them between 34 and 36 weeks, depending on other factors in the pregnancy. So the main take-home message with that is, if you do an ARM, or if there's, the midwife's done an ARM for an induction, and all of a sudden there's a significant loss, bloody loss with a bradycardia, think vasoprevia, and no one will ever criticise you for doing the category 1 section. Is that okay? I think we're almost done. So next thing, uterine rupture. Again, this is something that isn't particularly fun, but we will all be involved with this at some stage or other. And I remember my first encounter was actually as an ST1, and I remember that ST3, she had just started a new unit, and there was a patient in the observation area who hadn't actually been monitored. She was a VBAC, and the midwife happened to go in because the patient buzzed and said, oh, the CTG can't pick up the fetal heart, whatever. And actually there'd been a fetal bradycardia for about 7 or 8 minutes. And we took her for a category 1 section, and this baby was just in the abdomen. Baby unfortunately didn't do well at all, and the uterus was a complete mess to put together. But that, I will always remember, was my first encounter, and unfortunately there have been more since then. But it's although we counsel patients, say it's a risk of 1 in 200, that's with a VBAC, so it's not very common, but you'll see it through your training, so you need to be aware of it. Now, what signs or symptoms might suggest uterine rupture? Do you think vaginal bleeding?
Yeah.
Yeah.
Poor progress?
Yeah.
Good. Maternal tachycardia?
Yeah.
Yep.
Hematuria?
Yeah.
Abnormal CTG?
Yeah.
Yep.
Yes, and then cessation of contractions.
Yeah.
Yes, all of those. I know it's all very straightforward. But also on the CTG point, sometimes it might be a late feature because it will depend on where the placenta is.
One second.
Okay. So the CTG may not be necessarily abnormal to begin with, or maybe there might just be slight changes. So maybe there's a bit of fetal tachycardia or reduced variability. So again, if you're not going to have a typically abnormal CTG, and then you're going to think, oh, she's a VBAC, abnormal CTG, it must be uterine rupture. You need to think about all these other signs and symptoms. And obviously I haven't mentioned scar pain here as well, which always becomes more difficult to assess if someone's got an epidural on board. But generally speaking, if they've got significant scar pain, sometimes it can break through the epidural, so that's something else to be aware of as well. So what is uterine rupture? You've got uterine rupture and you've got your scar dehiscence, two slightly different things. So uterine rupture, full thickness of the rupture from the endometrium, myometrium, and then the serosal surface as well. And sometimes the fetus placenta may be in the abdominal cavity. Scar dehiscence is everything up until the peritoneum, basically. And sometimes you'll see that section, and there's just a thin film of peritoneum that's holding that uterus together, and that's a dehiscence, and that's quite lucky. That's a near miss, really. So I said the risk of rupture is 1 in 200. Obviously, the risk increases with induction or with augmentation, and it increases by 2 to 3-fold. And that's something that's important to obviously tell women when you're counselling them for VBAC, and obviously when you're seeing them in labour. And then just a note to say that rupture is rare with an unscarred uterus, but it usually happens in multiparous women. In what situations might we see then someone that's a multip who has scar rupture? In what scenario might we see a rupture?
When there are oxytocin.
Yes. Who was that? Who was that, sorry?
I think two of us.
Me and Joshua.
Okay, well done, yes. So that's why we always have to be very cautious when we're using oxytocin in multips, because we're worried about the risk of rupture. So again, something else to be aware of. And it's fine to start off, you start off with a little bit of the symptom, and then once the patient's contracting, and it'll be obvious, she'll start contracting of her own accord, you then reduce and then ideally start the oxytocin, and she'll just carry on contracting. But that's where we might see a rupture in a multip. So risk factors can be high parity, if they've had previous surgery that's breached the cavity. So things such as a myomectomy. Again, if they've had a uterine perforation at hysteroscopy, it's very benign, isn't it? You guys will all do it at some point. You'll perforate the uterus and think, oh, it's fine. The uterus is a very forgiving organ. It doesn't bleed. It will heal over fine. But you still cause a point of weakness, so to speak. So there is a risk of rupture. And technically speaking, she should be treated as a VBAC. So again, something to be aware of. Other risk factors: induction, hyperstimulation, malpresentation, a big baby, any uterine abnormalities, and then obviously trauma. Quite obvious. Obstetric manoeuvres. Which manoeuvres might we be thinking about?
ECV.
Yeah, ECV. Not seen it. I have to say, I don't even mention it to patients. But I think combination maybe big baby, lots of force potentially, but it's very uncommon. So when we talk to women about having vaginal birth after cesarean, who who can try for a VBAC. So obviously if they've got a singleton pregnancy, if it's a cephalic presentation, the 37 weeks or beyond, and they've only had one cesarean, and then ideally, I mean, if they've had a previous VBAC, they've had a successful VBAC, then their chances of another successful VBAC increases significantly compared to someone that hasn't had a VBAC before. But that's generally your criteria for women who can have a VBAC. Now, when would we not recommend, or when would it be contraindicated to have a VBAC?
If at the last cesarean section the incision was extended.
Elaborate a bit for me.
So if there's been an intentional extension into the upper segment.
Yeah. So what would you call that?
Section.
Yeah, classical section, or what you're saying, Joshua, is a T incision. So you've got your across the lower segment, and then you have to go up. So if you're going up somewhere along the midline, it's a T incision. If you're extending it on the side, that would be a J incision. So yes, you're right. So all of those are types of classical sections. So yes, VBAC's contraindicated there, simply because there's a higher risk of rupture. Yeah. So what else? What about the number of cesareans you've had? Does it matter? So if I'm someone that has had someone who's had 2 cesareans, I want to have a VBAC. What do you think about it? And I want to go up on the birth centre. Good idea.
I think you go to the birth centre.
Why not?
Well, because of the risk of rupture, isn't it?
Yes. So what the evidence shows us is if you've had 3 or more cesarean sections, then it's a definite no-no. You must not attempt any VBACs. You need to have a planned cesarean. If you've just had 1 cesarean, then the recommendation is obviously for a VBAC. Risk of rupture is 1 in 200. So providing there aren't any other mitigating circumstances, try for a VBAC. If you've had 2 cesareans, actually, the evidence is quite limited, and it shows it doesn't significantly increase your risk of rupture compared to 1 cesarean. So technically speaking, if you counsel your patients appropriately, they're well motivated. Ideally, they will deliver on labor order. I've had someone VBACing with 2 cesareans up in birth centre before. It's quite unnerving. But, you know, if she goes into spontaneous labour, all the conditions are right, so it's not a big baby, it's a singleton baby, blah, 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 then actually patient choice and all the rest, she can do it. So long and short of it is, if you've got someone that really wants to have a VBAC after 2 sections, counsel her appropriately, but technically speaking, yes, she can. So you will come across that sometimes. Let's see, obviously previous rupture, that's a no, previous classical, and any other contraindication to vaginal birth. So if it's, I don't know, breech, or she's got a lower line placenta, that obviously goes without saying. So counselling, we've said this, using oxytocin and things that increases your risk. And success rate, I mean, the college says the success rate is between 72 and 75%. I think that's extremely optimistic. I would agree that if they've had a previous VBAC, then yes, their chances are about 90%. But I don't know how many of you look at your local data, but at Reading, we're between 50 and 60% of women who actually successfully VBAC. And again, I think when you're talking to patients, it's important to know what your local hospital's statistics are like, because it's all very well to say, oh yeah, you've got a 75% chance, but actually if you know in your unit it's only 15%, it's only fair for the patient to have the accurate information. So it's just something worth finding out. What's your successful VBAC rate? Because you'd be surprised that it wouldn't be nearly as high as 75%. But definitely, if they've had a successful vaginal delivery before, then yes. Right, these are all the things with uterine rupture, isn't it? Okay. So finally, how do we, just to put it all together, how do you manage an APH? Actually, it doesn't matter really what the causes of the APH. Your first priority is always maternal resuscitation, so the whole ABC, cannulate, take blood, group and save, cross match, so all your basic stuff such as that. Then in terms of obstetric management, again, depends on the amount of bleeding, the gestational age, and if the fetus is alive or not, if it's still alive and preterm. give steroids as soon as you can. If they're very preterm, obviously less than 32 weeks, you need to give magnesium sulfate. And then you need to think about whether or not this patient needs to be delivered. It's easier when someone's term or towards term, but when you've got someone that's between 30, 34 weeks and they're preterm and things, it gets a little bit more difficult. And then in terms of third stage, remember the phrase that APH weakens, the PPH kills. So someone that's had an APH, obviously significant APH, not someone that's just had a bit of spotting, but they're more likely to have a PPH, more likely to have clotting abnormalities. So make sure you think about it, correct any clotting abnormalities, replace the blood loss. So, good fluid management, blood products as needed, and then active management of the third stage. Oh, okay, we've got a couple of minutes. So these are just some SPAs which I've got from, I can't remember where, strategy module, that's it. So let's just go through these quickly and then there'll be time for your next talk. So 37-year-old who comes in with an APH and tightenings at 34 weeks. She'd had a scan at 32 weeks showing the low-lying placenta. CTG is normal. There's some uterine activity, but otherwise it's fine. What would you do? Single best answer.
Steroids.
Anyone else? Do we all agree? Does that seem the most appropriate thing to do? Good. I'll take that as a yes. So tocolysis, this seems to have fallen out of fashion. So this was the use of medications such as nifedipine and other such things that would reduce uterine activity. But you wouldn't do it in this situation because if she's bleeding, there might be a chance that she might need to be delivered. So there's no point wasting time in trying to reduce her contractions. Steroids, yes, because you might need to deliver her and she's obviously preterm. Clyhauer, you would want to do it at some point, but it's not your first priority. Ultrasound, again, chances are it's probably going to be abnormal, possibly breach, but your CTG is normal, so you know the fetal heart is there. There's no massive, and you're not going to be assessing the placenta, so really it hasn't got much of a role. And then VE, you're not going to do a VE, are you? Because she's got a low placenta. You might do a gentle speculum because you want to see if the cervix is opening up or not, but you're not going to then stick your fingers in, so that's quite obvious. This time, the 39-year-old primate comes in with a history of painless bleeding around 32 weeks. It's her first episode, and at home, blood has soaked through her clothes, down her legs, and filled 2 sanitary towels. By the time she comes to hospital, it's all settled. And at the 20-week scan, it showed that the placenta was covering the cervix, and she's having another appointment in 4 days' time. What would you want to do for her?
The third option.
Cross-match commit steroids.
Good. Anyone else? Great. So we all agree. I mean, you're not going to start fiddling around and putting in a stitch. That's just foolish. You definitely want to cross-match and you definitely want to keep her in, but actually you want to give her steroids as well. And that's why the third option is the right option. You're not going to say, and obviously you're not going to say to her, oh, actually, there's no bleeding now, off you go and come back in 4 days, because she's given a significant history of bleeding. You know, if the blood is run down her legs, usually there'll be some dried blood on her legs. Most women wouldn't take the time to clean themselves, then call the ambulance or come into hospital. So look for those signs. But even if there's no active bleeding, when you speculum her, if she's given you that history, believe the history and keep them in. And again, you're not going to use tocolysis, like we said. I think this is the last one. 35-year-old Para 2 who's coming for post-states induction. Her first baby was a normal vaginal delivery, second one was a cesarean, so this would be a feedback for her. Cervix was 2 centimeters dilated -1. She has an ARM, it's light core is clear. She started on Synto and the epidural was put in. 3 hours later, she complains of sudden constant pain. The CTG had been normal, then shows atypical decelerations with slow recovery, difficult to pick up the fetal heart. She's only 5 centimeters, and now the vertex is not in the pelvis and the light was blood stained. Couldn't be any more obvious. So we're dealing with
Rupture.
rupture, and you're going to do
Grade 1.
grade 1, yes, grade 1, category 1. Call it what you like, but you need to get that baby out, don't you? Lovely. Perfect. So these are just some other bits that you could look at for more information. The strategy module is actually very good. It's quite long, but it goes into a good amount of detail. And obviously familiarise yourselves with the birth after cesarean green top guideline. And as I say, it's useful to know what your local statistics are, so you can counsel these women more accurately. And I would say, especially with feedback, it's really important that you document accurately, provide all the information leaflets, and make sure the patient understands as best as possible. So that is everything from me. Any questions at all?
Thank you, that was really good.
Great.
Ms. Johan, ask a question slightly off topic.